Hello, I'm Chow Sang. I'm a colorectal surgeon. Do you know that colorectal cancer is the top cancer in Singapore, and gastric cancer occupies the top 5 spots as well? As a doctor, I often encourage my patients to go for colonoscopy screening. The reason is simple. Early detection of cancer means a better chance of survival for our patients. And if one were to go for a colonoscopy exam, one can also do a gastroscopy as well, as the preparation is simple. All it takes is another 6 hours of fasting, and the procedure takes another 15 to 30 minutes. But many people still shudder at the thought of going for a colonoscopy exam. What stokes their apprehension is this: having to take a powerful bowel cleansing agent and coping with the diarrhea that follows for 6 hours after that is something that none of us will enjoy. To help you overcome your fear, let me walk the talk. I'll be the patient, and it's just as well, I'm 50 this year. Let me take you through the entire procedure, from preparation to recovery at Mount Elizabeth Novena Hospital, and you'll discover that it's actually fuss-free. One of the things about preparing for colonoscopy is that you need to clean out your bowels. And so it's important to take an early dinner. As you can see, everything is very soupy. There's no residue in my diet. It's no vegetables, no fruits for dinner tonight. Everything is going to be very easily digested. Whatever I'm eating tonight is going to come out very quickly when I take my bowel prep. It actually tastes quite good. Well, that's my dinner. I'm done. Well, it's 1 hour after dinner, and that's why we have to start early, before 6 o'clock. And we have 4 pitchers of water here. One pitcher is 1 liter, and we're going to mix this into the 4 pitchers of water. This is the bowel preparation I was telling you about. 1 packet of powder goes into 1 pitcher, and we have 4 packets this evening. So let's get going. Effectively, the mixture will just flush your intestine clean of any stool residue. Well, here's the first pitcher. And all I need to do is to start drinking this. Bon appetit. It's actually quite yucky. What you can do is you can get some orange juice just to sweeten it a little bit. And if you can drink all this within 3 hours or so, I think you'll be fine. So it's going to be a long night. It's starting to taste like soap water now. I think it's important to keep drinking even though you start going, because it has to be very, very clean. And when I say clean, I mean that when you pass out, it's all liquid with no residue. I don't think I can sit down anymore. Well, as you can see, 4 empty pitchers. And I've been to the toilet many times already. It's getting very clean. It's not difficult. Well, I'm empty and I'm exhausted. I'm going to turn in for the night. Good night, and I'll see you tomorrow.
Oh, there you go.
You have no idea.
You finished all the prep?
Yes, completed every single last drop.
Did you sleep well?
Yes.
Okay, so we're ready to go.
All set.
So we're going to get the gastroscopy done first, and then the colonoscopy, right? So what I'm doing is a pre-procedure check, making sure that Charles has completed his bowel preparation and that we're ready to go. So how was his effluent? Was it good?
Yes, good, clear fluid, nothing else to pass.
Okay, so we're going to take a set of vital signs before he goes down to endo.
That's right.
Okay. All right.
All right. I'll see you downstairs.
Okay.
Good morning, Dr. Chia.
Good morning.
My name is Staff Nurse Chet. I will be the nurse who will be in charge for you today.
Okay.
Allow me to check your parameters.
Sometimes patients do get very excited, so the blood pressure might go up a little bit. So we'll see. You can see for yourself whether I'm excited or not.
Yes.
All systems go. Well, this is it. Feeling a little bit apprehensive, but I think I'll be in good hands. So far, so good. Of course, a little bit of nervous. You never know what you'll find, but I think it's better to check. Don't you think so? Alright, I'll see you guys on the other side. I'm raring to go.
Filters your nose,
Charles is getting some anesthetic spray into his nose that will numb the sensation as we prepare to put the gastroscope through the nose. Okay. This is a fairly new technique where in the past the gastroscope used to be inserted through the mouth. That causes a bit more discomfort because it irritates the back of your tongue, so there's more gagging. So this time we are using a smaller scope, which I will show you later, and it's more comfortable for the patients. Okay?
Sniff again. Give a sniff. Okay, good. I'm going to just open your mouth now. Just spray it in there. Okay, just take out your tongue now. Okay, swallow. And give a cough. Just give a cough.
We'll have to see.
Okay, just spread it around.
Depends.
In there.
If you find
Okay.
that there's a polyp,
bit
then
bitter,
you
huh?
go through the other nostril.
Getting numb in there? Just a bit, huh? You should get quite numb in a very short while. So what?
Oh, that's good.
Can't feel already, eh?
Very good.
That's the whole idea, eh?
So now we are getting Charles in position. This is the position that we adopt for all our procedures, which is on the left side. We'll give him some oxygen. So that's the monitor over there, and you can see that we're monitoring the pulse rate, the oxygenation, and the blood pressure. Okay.
Okay, Charles. All ready to go?
Where am I getting?
You're getting some Domicum first. Then after that, you'll be getting a little bit of propofol and fentanyl. Okay? This is going to let you forget. Alright? I'm going to wait for it to work, and then after that, once I think it's okay, I'll tell Dean to carry on for you.
This is the scope that I will be using. This is a fiber optic scope. You can see that it's flexible, and with the dials I'm able to control the tip of that scope one direction. With the other dial I can control it in the other direction. And there are two buttons here. One is for suction and one is to blow air into the organ, either the stomach or the colon. So we're going to start with the stomach. So I'm going to insert this into Charles's through the stomach through his nostrils. Okay. So let's have some gel. So we're going in through his throat. Okay. Into his esophagus. That's the esophagus, which is the gullet that connects your mouth to the stomach. And we're entering the stomach right now. There we go. So we're in the stomach right now. And the next thing that I will be proceeding to do is to enter the first part of the small intestine. So can we have some flush, please? Thank you. Okay, you see the lumen there? That is the opening into the first part of the small intestines, and we're into the small intestines. Thank you. The endoscope has the ability to pump water in to irrigate the surroundings so that it removes debris so that you get a better view. Okay. So now I'm into the second part of the duodenum. And everything looks good. So I'm going to take some pictures now. So by pushing a button, I'm able to take pictures as well. Oh no. Okay. Okay, that's one picture taken. Another picture taken. Coming out to the first part of the duodenum. Now, evaluation is performed when we're pulling out the scope, not when we're putting it in. So putting it in just involves inserting the scope to the start point. So once we've gotten to the start point, then we have a good look. Okay. Now, what is the role for gastroscopy? I think in people who have a strong family history of cancer, typically cancer of the stomach. The other indication, of course, is if you have very bad gastric pains, what we call dyspepsia, that is not relieved with your standard gastric medications, then I believe it's always good to have that checked with gastroscope. You can see that the direct visualization is superior to any form of other tests such as x-rays or scans, because you're actually visualizing the lining of the stomach. So I'm suctioning out whatever fluid I have in the stomach so that I get a better evaluation. Okay. There we go. This part here is the scope coming in through the esophagus. Looks good there. That's good. No evidence of ulcers up here. Okay, so what you see here now would be the lining of the stomach. That's the body of the stomach, entire body of the stomach. Erosions there. This one here looks good. Now, is there a risk for gastroscopy? The risk is absolutely minimal. We're talking about a 0.1% risk of injury to the lining of the stomach. Okay, let's do a core test. I'm about to take some tissue from the lining, and we're testing for the presence of a certain bacteria that is commonly associated with gastritis or gastric or duodenal ulcers. And it's a simple test. All I'm doing is I'm just taking a bit of small little tiny bite, smaller than 1 millimeter. Open, close. Okay, and there you go. And we'll put this in a mixture that will determine whether there's a presence of this bacteria. The reason why we do that is because if it is present, this bacteria can be eradicated very simply by a course of medication. So it's good to always do a routine test, especially if there's presence of erosions, gastritis, inflammation, or presence of ulcer. So now that's the end of the gastroscopy. I am just suctioning all the air that I have pumped into Charles's stomach so that he doesn't feel so distended. Suctioning all the air out, and I'm gradually going to pull the scope out of the stomach. Okay, good there. Out of the stomach, coming into the esophagus, which is the gullet, and slowly withdrawing, having a good look at his esophagus. Everything looks pristine, looks good here. And suctioning the air out as we go along. And let's get the scope out. There we go, all done. So you can see now that what we've done is we have turned Charles around so that we're in position to start the colonoscopy. Christine here has just swapped the transnasal gastroscopy unit with colonoscope. Okay, the colonoscope is actually a longer version of the gastroscope. It is a bit thicker in diameter. It goes through the anus, and we will work our way along the Charles's colon, starting from the rectum all the way to the beginning, which is the cecum, and we're going to try to look for his appendiceal opening, which will tell us that he's at the cecum. As you can see, it is a longer version of the gastroscope and a thicker version. Otherwise, the dials are identical, and gotcha. And this is the light source unit over here. So the light is transmitted from this unit all the way to the tip using fiber optic technology so that we can see what's inside. The difference between colonoscopy and a gastroscopy is, of course, the colon is a lot more, make our way up now. The colon is rather floppy. So that means that it's not fixed like where the stomach and the small intestines are, or the first part of the small intestine is. So getting the scope through that is usually a bit more tricky. So at the age of 50, you need the recommendation is for you to undergo a colonoscopy, a strong family history of certain types of cancer. Cancers would be an indication for colonoscopy as well. All right. So, for example, if you have a family history of colon cancer, breast cancer, cancer of the womb, all these would suggest that you should consult your doctor to determine if you are at risk of colon cancer and whether you should have colonoscopy performed. Now, you will know that the appendix is situated in the cecum, which is the first part of the colon. And once we have that visualization, we are certain that we're there. Okay. So I'm going to just gently insert that just a bit more. There we go. All right. I'm taking a picture of the appendiceal opening, and that is definitive proof that I'm at the beginning of the colon. And now I'm going to start evaluating, and essentially what most of us endoscopists look for when we do this procedure is for the presence of polyps. Polyps are small growths on the lining of the colon, and the significance of polyps would be the fact that these can potentially become malignant or potentially turn cancerous. So therefore, it's absolutely important that when we evaluate, we actually can see, look at the lining carefully. So you can see that whenever there are areas that are covered by fecal matter, that I can actually employ a device, as you can see there, that squirts water in, and that allows me to have a good view of the colon. So far, everything looks pretty good. Okay. Now, what's the importance of polyps? I think when we do see polyps, we have to remove them, because by removing the polyps, we actually prevent them from becoming cancerous. So that's actually preventive. So the entire paradigm of screening in colorectal cancer has changed from that of detection to prevention. So the idea is that if you can prevent colon cancer, you should. So if you have colonoscopy, as we're seeing here, and we see polyps, remove them on the spot. If you've had a colonoscopy and the colonoscopy is clear, you actually do not need to undergo colonoscopy again for a period of 5 to 10 years. The risk for colonoscopy would be slightly different from that of gastroscopy. The risk ranges from 0.1% to 0.3% to 2%. Now, 0.1% would be risk of injury to the wall of the bowel. And if there's a need to remove polyps, then there's usually up to 2% risk of bleeding from the site where we've removed the polyp. The risks are exceedingly low, and again, with experienced endoscopists, these risks are fairly negligible.